Hi, this is Brian Kim. I'm going to share with you this case of a patient who had a moderate lens density and received a Panoptix trifocal lens. I did double chop, cross chop, mechanical fracturing. And I'm also going to be switching to a 2.4 millimeter incision from a 2.6. You'll see I'm going to be using a metal blade as we transition and change out our diamond blades. But you'll see the sleeve is different, the incision's a little bit smaller, and you'll just see if there's any difference in my technique here. So I'm going to go ahead and place a corneal marker to help me center and size my rhexis. I'm making my paracentesis incision on the right side and then left side. I believe this is a right eye. I want to make my paracentesis incision flat to the iris plane so I can achieve a self-sealing corneal incision. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic to fill the anterior chamber. And I'm using that cannula to hold the eye steady, and I'm turning it away. I'm making an incision close to the limbus, stabbing with the blade, tunneling through the cornea, using the cannula to turn the eye towards me and then enter. And so I'm using a biplanar technique with the metal blade. This is a puncture-style capsular rhexis. I puncture with the teeth of the forceps, pull down. I grasp the right side of the tear and start to create a flap. And I'm going around circumferentially, counterclockwise. You can see I'm able to still do my technique the same exact way, same forceps, through this 2.4 millimeter incision. This is the Capsular Phonics Hydrodissection technique. I'm placing the cannula out to the equator, contra-incisionally, point the tip downward, get a nice fluid wave, fill the bag up, decompress it, and then turning the tip down, and I'm able to spin the lens on the right side. I'm adjusting the sleeve length to make it appropriate for me, irrigating the surface, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. And I'm going to remove the surface epinuclear material. I'm going to place the chopper underneath the epinuclear ridge out to the equator, rotate the phaco tip vertically, sub-incisionally, bring both instruments together, crushing the lens completely in half. That's the double chop. I place the chopper out across the right heminucleus, pulling it centrally, crushing the right heminucleus in half, and that is the cross chop maneuver. I'm lifting up that first quadrant with a little bit of vacuum and using the chopper to lift it as well. I'm sandwiching the lens pieces into smaller pieces and emulsifying the lens piece. Using some vacuum to lift that second piece up, using mechanical fracturing forces to crush the pieces into smaller pieces, and then emulsify the lens pieces. I'm going to place the chopper underneath the rhexis edge around the second quadrant, pulling it centrally, crushing it against the phaco tip, and then lifting that piece up with the vacuum, and then sandwiching it between the chopper and the phaco tip, and then emulsifying the lens pieces. Place the chopper around the lens piece, pulling it up, grabbing it with a little bit of vacuum, sandwiching the lens piece again between the chopper and the phaco tip, and then emulsify the lens pieces. I'm going to rotate the second heminucleus in front of me, place the chopper around the lens piece, pulling it centrally, crushing it against the phaco tip, dividing the lens into a third and fourth quadrant, placing the chopper around the third quadrant, pulling it centrally toward the phaco tip, dividing it and crushing it into smaller pieces, and then emulsifying the lens pieces. Grabbing that second piece, crushing it against the phaco tip, and then once they're small enough, I'm using ultrasonic energy and vacuum to emulsify the lens pieces. This is the final quadrant. Place the chopper around the lens piece, pull it centrally against the phaco tip, dividing the lens piece, crushing the lens piece between the chopper and the phaco tip, And when the lens pieces are small enough, I'm emulsifying the lens pieces. And this is a final piece. I place the chopper around the lens piece, crushing against the phaco tip, sandwiching the lens pieces between the chopper and the phaco tip into small bite-sized pieces, and then emulsifying the lens pieces. Now that the endonucleus has been removed, I start to remove the epinucleus with a little bit of vacuum, and I'm placing the chopper deep to protect the posterior capsule. I take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. I like to start sub-incisionally first, removing the sub-incisional cortex, trying to grasp the anterior component first, and then just kind of pulling mechanically as well as using high vacuum to tease off the cortex from anterior to posterior. And I feel like it's pretty clean. I'm switching to the polish mode, and I'm polishing underneath the rexus edge of any lens epithelial cells. Start to polish the posterior capsule surface as well, removing any fine lens epithelial cells as well as some fine cortical material. Once I'm satisfied, I go in with the BSS cannula, pulsing the sub-incisional space with the BSS, looking for any remaining lens material. The bag looks pretty clean, so I switch to the cohesive viscoelastic cannula, filling the capsular bag, and then I'm going to sweep underneath the rexus edge, first on the left side, sweeping all that lens epithelial cells, especially in the sub-incisional area. And then sweeping now on the right side. You can see the lens epithelial cells coming off with this maneuver in the sub-incisional area. So I'm going to inject a single piece acrylic intraocular lens into the capsular bag. The 2.4 millimeter incision is a little bit tighter, so it does require a little bit more effort to place the tip of the injector into the incision. I go in with the INA handpiece, making sure the haptic is off the optic. Go underneath the lens, tilting it, rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag and underneath the lens. And then I'm polishing underneath the rexus edge, switching to the polish mode now. And I'm rotating the haptics in the horizontal position. And once I'm satisfied, I switch to the visco mode, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So you can see this was double chop, cross chop, a fairly moderate lens density. And this is a Panoptix lens, and you'll see I'll use the Purkinje images to help center the lens. But this is a 2.4 millimeter incision, and I'm transitioning to that incision for a variety of reasons. One of my partners really prefers a 2.4, and we're trying to be as efficient as we can and try to standardize our techniques as much as possible. So I'm switching from a 2.6 to a 2.4. I do notice the incision is a little bit smaller. It does require a little bit more care with the rexus because you can't open the teeth completely open. But I do think sealing the incisions is a lot easier. I do also think that the injection of the lens implant is a little bit more difficult, does require wound assist in some cases. But overall, I think it's pretty similar to doing the case with a 2.6. Not much of a big difference. Definitely doing double chop and cross chop is no different at all between the two incisions. Again, I think the main thing is really the rexus. And I do feel like there's a little bit more fluid egress with the 2.4, because I think it's on the larger side for the pink sleeve for 2.4, whereas for the 2.6, the purple sleeve is really kind of on the small size for that incision. So I hope this was helpful to you, and I thank you for your attention.